Hello, my name is Natasha, and I'll be presenting our paper entitled Designing for Caregiver-facing Values Elicitation Tools on behalf of my co-authors. A brief content warning: we will touch on the subject of end of life, so feel free to skip this video if this is something you're not comfortable with. First, I'll describe our problem space, which revolves around end-of-life care decisions. Values are important in medical decision-making to choose care according to what's important to the patient. In making end-of-life care decisions such as CPR, extraordinary life-sustaining interventions, or places of care, values are crucial because extending life often conflicts with finances, time, and the patient's comfort. It calls for a mindset shift from solely seeking cures to prioritizing values, which is why these decisions are also called preference-sensitive choices. Even though we want to respect the patient's autonomy, they are often too ill to express their thoughts. Caregivers have to then stand in for the patient about half of the time in cases of serious illness. But they're often unprepared for this difficult task, and they may not know what the patient would want. In the TRIO framework, it illustrates the dynamic nature of shared decision-making where providers, patients, and caregivers collaborate. The circles here show how the nexus of decision-making could shift as the illness progresses. When the nexus falls on the caregivers, they would have to derive the patient values. While the health literature is quite clear on why it's important to understand values, it's not so clear on exactly how values elicitation should occur, particularly for caregivers. This drives the motivation for our research question: how should we design digital caregiver-facing tools that support the elicitation of patient values in the context of end-of-life care? We then look into the HCI literature to see how caregivers have previously collaborated with patients. We know that these collaborations can be complex. Caregivers and patients might want different things, and these values shape the dynamics of the cooperation. Studies have called for research that focuses on caregiver-patient partnerships and to balance conflicting motivations. Beyond values, the literature also describes the work of caregivers in managing care. This can be described as articulation work, where caregivers are clarifying and coordinating information, acting as intermediaries and boundary actors for managing care with other people and different events. The studies have also identified the work of managing relationship. In the hospice or palliative care contexts, these works seem to be exacerbated, with one study describing the emotional drain from having to repeatedly communicate the same patient update with many people. These authors called for sharing systems that allow for quick but controlled dissemination of information. The current study contributes to this body of work on caregivers as collaborators by describing caregiver behaviors in values elicitation towards shared decision-making. Here are some recommendations from HCI literature about interactive tools for patient values elicitation that also inform the design of our tools. Moving on to the design process. We used a research-to-design approach where we created 32 low-fidelity prototypes through Crazy 8's exercises. From these, we selected 4 prototypes based on design considerations and added 1 more later on. The tools are Storytelling Tool, where the user's input would generate a story about the patient with values derived from patient interviews. Serious Illness Conversation Tools, which adapts a clinician conversation framework. Happiness Profile Tool, which produces 2 AI-generated images. Choice Box Tool, which goes through the costs and benefits of a selected decision. And Task List Tool, which was developed after user feedback, gives a checklist of prioritized tasks for caregivers. Collectively, these prototypes helped us to investigate if sources of values matter, how to balance between input burden while encouraging thoughtful reflection, the optimum level of ambiguity of outcomes, and how to facilitate sharing. Here is a detailed breakdown on how each prototype corresponds to the parameters that we investigated. We interviewed 12 caregivers for their feedback on these prototypes, asking them to envision receiving these tools from the doctor in the context of end-of-life care. We analyzed the interview notes using affinity diagramming and thematic analysis. Here are the findings according to design parameters that we sought to investigate. Firstly, getting values from patient-derived or provider-derived conversations were both deemed helpful, as they provided a structured guide for reflection. Yet, some participants felt that it's only right if the patient is the one answering the questions, while others had conflicts between their own values and the patient's values. For instance, one participant faced a dilemma when the patient refuses treatment, leading him to answer based on what he thinks rather than what the patient might answer. For the type of input, unsurprisingly, shorter inputs were preferred, as they felt more achievable and less burdensome. This is important to note given the context of caregiving burden and the limited time that caregivers have. What surprised us is that short inputs can also stimulate thoughtful reflection. For instance, a simple question on what does the patient like to do managed to prompt elaborated reflection about the patient's identity and creative thinking to improve the patient's quality of life. This shows that well-crafted question doesn't need long inputs to provoke thought. Moreover, elements of delight, such as bubbles in the storytelling tools, provides to be a useful counterbalance for the tough questions. In terms of output, the pictures were nice, but not very useful for most. While bullet points were appreciated for being clear and concise, some felt that it's insensitive and inappropriate to think of the patient as a job done, or to consider the cost-benefit of sustaining life. A good middle ground comes from the generated narratives, which gives the language to represent the patient's values while preserving the patient's dignity. Lastly, participants did want to discuss the tool's output with their families. Even though they appreciated the voting, forum, and chat systems, ultimately WhatsApp, which is a messaging app, was the most preferred sharing method because it felt easy and instantaneous. On top of the findings on design parameters, we observed two interesting insights. When participants discussed about sharing the tool, some were open to show the tools to their families, but others act as gatekeepers, wanting to filter the information first. They cited language barriers, technological barriers, or expected resistance as reasons for not wanting to share directly, as their family might not want to use such tools for emotional matters. These caregivers would rather take the insight from the tools and share it later, or use the tools to support their points when discussing with others. There is also a split between perceptions on how useful values elicitation tools are among our participants. The values elicitation were seen as useful for those who already believe that patient values are important. However, values elicitation were deemed as not useful for those who disagree with the patient, heavily rely on information or doctor's advice, or are heavily constrained by time and finances. Here is a visual summary of our findings. Moving on to design recommendations. There is no point in designing a perfect tool if nobody wants to start using it. And as we discussed, some caregivers did not see the point of eliciting values against more tangible needs such as information, support, and resources. One way to explain this finding is that in Asia, where our study is conducted, there is an inclination to just follow whatever the doctor says. But crucially, caregivers may not realize that end-of-life decisions require prioritization of patient values instead of a purely curative mindset. Thus, we recommend designing with educational and motivational components in mind to situate values elicitation in the journey towards preference-sensitive decision-making. In the beginning, we wanted the tools to be an aid for caregivers to elicit the patient's values. However, it is difficult for them to guess what the patient wants. Sometimes the patient themselves might not know it. It's even more difficult when the caregivers disagree with the patients. As designers, we encountered a dilemma. Should we prioritize the patient values or adapt to support the daily practice of caregivers? especially considering the Asian context when the family wishes usually prevail. In the end, we chose to retain the primacy of patient values, aligning with our country's regulations. Yet, we also recognize the importance of supporting the caregiver in working out their values. Thus, we recommend supporting working out of what's important to both the patients and the caregivers, with the aim of clarifying the collective decision model of the family. In this case, one strategy that could help to uncover shared values is by externalizing the beliefs underlying the values. In other words, even though the preferences appear different on the surface, finding out the why behind the preferences could help caregivers and patients find a common ground. But as with anything dealing with end of life, it needs to be trauma-informed, maintaining an empathetic tone, positive affect, and even a narrative approach. The reasoning for this recommendation is informed by the research in HCI on values in design. In the literature, there is a tension between top-down or bottom-up approaches towards values elicitations. While top-down approaches can promote certain ethical ideals, bottom-up strategies take into account localized constraints better. For example, people are often unclear what their values are. And Mary Moore coined the term care tinkering to describe this process in care, where good care is not an ideal as much as a process of persistent tinkering in a world full of ambivalence and shifting tensions. We did find some evidence of this tinkering as participants want to discuss with other patients and caregivers to fill out the tools, consistent with a bottom-up and collaborative approach to understanding values. Yet, caregivers also appreciated the structure given by the provided questions, suggesting the benefits of a top-down approach. Therefore, we recommend that digital tools find a balance between both of these approaches to values elicitation. The caregivers in our study values family consensus highly, so when they struggle to articulate a patient's values, they want to consult a spokes group of close others to help decide. Yet, they tend to want to filter the information from the tools, given the sensitivity of the topic. Hence, we recommend a staged approach where caregivers can first use the tool privately to clarify their own values before optionally triggering collaborative features for use with others. Alternatively, designers can consider producing shareable takeaways such as discussion agendas, conversation preparation aids, or values visualizations, which can serve as reminders of the patient's personhood. To conclude, going back to the research question of how should we design digital tools that support caregiver-facing elicitation of patient values, here are the tasks that caregivers need to do in values elicitation and our proposed design requirements. The first column shows tasks that patients complete when using values elicitation tools. In the next two columns are corresponding tasks for caregivers, which we have found from our study. We envision the tasks to be done with or without the patient, as the nexus of decision-making may shift depending on the patient's condition. Notably, caregivers need to go beyond eliciting values to also resolve differences that may arise. Lastly, we list the design requirements for in each of the phases. Caregivers may initially use the tools by themselves as a background aid and only share it with others if they consider it appropriate. And that marks the end of the presentation. Thank you for your time.